Hey there. Good evening, America. Guess what time it is? It is 5 o'clock Central, which means 6 o'clock on the East Coast. Uh, Boy, then I lose track. 4 o'clock in the mountains and 3 o'clock on the West Coast. And it is time for Fertility with Fink. My name is Dr. Randy Fink from New Life Fertility in Pensacola, Florida. And I am very pleased to have with me here this evening Jessica Williams. Jess is our nurse practitioner in the Dothan, Alabama office, and that's where I am tonight. We are in Dothan, Alabama. I have been here for the last couple of days, and we try to come here. Well, Jess is here every day. So, yeah, Jess lives here, but I'm here at least monthly. And welcome to all our friends who are joining us as we do every Tuesday evening on Fertility with Fink, where it gives you the chance to talk to us about things related to fertility and women's health and all that stuff that is important to you. Every week, it's the same time, 5 o'clock Central, Fertility with Fink. And if we aren't able to get to your questions, we do have a nice email address to which you can send your questions. And that is askfertilitywithfink@firstfertility.com. Easy enough. Let's say hi to all our friends who are joining us. Hello to Ashley. Yes, Danil, I think is what that says. Hi, Sharmila. Nice to see you. Hey, Midgie. Brandis, my wonderful friend, the nurse practitioner in Colorado, is here. Hello, Ray and Tracy. Nice to see you. M. Salustio, good to see you again here as well. Hello to, I think that's Angela. Hello to Angela over there with that crazy handle that I cannot pronounce. We've got a couple of different feeds going on here. We've got Facebook and LinkedIn and YouTube, and we've got my Instagram, which is here, Randy Fink MD, as well as New Life Fertility, which is right over here. Feel free to ask your questions. And also, if you would prefer to email, we can do that as well. And that's askfertilitywithfink@firstfertility.com. Let's dive right into a question that we got from a very nice lady who has been watching us. I didn't see that she joined us here yet, but so she'll be very sad when she finds out that we answered her question here. This comes from Stephanie. Stephanie kind of has a long and a complicated history. She has recently done 6 cycles of both medicated and unmedicated timed intercourse and intrauterine insemination at her practice now. She's 46 years young and has endometriosis. She had a history of severe preeclampsia with a prior pregnancy has decided to use donor sperm for a couple of different reasons, but so far hasn't had much luck with her IUIs. And her question is, will my body do any better with donor egg IVF than the medicated timed intercourse or IUI cycles? And the answer to that is 100% yes, absolutely, completely and positively yes. And why is that? Well, so at 46, as I always tell people, and it's kind of not fair, that the sperm that comes out today from the male partner was manufactured in his body about 3 months ago. But in the woman, all the eggs that you will ever have, you were born with. And so over the course of our lives, we start to lose those eggs. Those eggs, the DNA, the genetic material in those eggs becomes less stable. And so it gets harder and harder for us to be able to get pregnant as we mature. And at 46, the odds of achieving a pregnancy with timed intercourse or with IUI are unfortunately extremely, extremely low. In fact, I would tell you, Stephanie, there that the odds of being successful with IUI at 46 are probably not much better than you would have simply doing home intercourse. So not surprising, 46 is tough because the DNA in those eggs has gone through a lot of challenges. So even in nature, it's very hard for someone who is 46 to be able to get pregnant. Now, does that mean it can't happen? Absolutely not. It can happen. That is not what that means. But when we're talking about doing fertility treatments, it just makes it considerably more difficult. When we use a donor egg for IVF, we are using genetic material that comes from someone who is probably on the order of 22, 23, 24 years old. So the DNA, the genetic material in those eggs is very, very stable. So the odds of being able to fertilize one of those eggs to create a nice normal embryo to place back in you is an order of magnitude higher than it would be trying to use an egg at 46, or even whether that egg is outside of you as it would be in IVF, or inside of you as it would be with IUI. So I would say you are looking at a very, very tough climb to reach a pregnancy at 46 doing something like IUI or using your own egg. But you're looking at a very straightforward process using a donor egg at that point. So straightforward that I would say, depending on the clinic and the lab you're using, you may have up to anywhere from a 40 to a 65% chance of pregnancy with any one of those embryos, as opposed to using the embryos that come from you, or even with an IUI, looking at far less than a 1% probability of pregnancy. So that's my 2 cents worth on that. Let's talk a little bit to Jess. Jess, as I mentioned, is a nurse practitioner here at New Life Fertility in Dothan, Alabama. Jess is also a certified nurse midwife. What is a midwife, Jess?
Midwives are great. We do a lot of things.
You deliver babies.
We deliver babies, but we do more than that. For women, we can be primary care providers. We do obstetrics. We do gynecology. Obviously, we do fertility. So it's really versatile, the degree, but we do deliver babies. And
now you currently work in a hospital setting to deliver babies, right? And that is where? That's in Tallahassee.
Yes, Tallahassee Memorial Hospital. Usually I'm there on the weekends, and it's a wonderful place to deliver a baby.
It's fun to deliver a baby, right?
It's the best, yes.
Definitely fun to deliver a baby. There are some midwives who deliver babies at home.
That's correct, yes.
There are different types of midwives. Now, you are a certified nurse midwife. What is the other type of midwife?
So there are a couple of different types of midwives, actually. You have your lay midwife, as people commonly kind of refer to those. They don't really have as much formal training. And then you have a certified professional midwife who they actually do go through training. They do go through a master's program, and it's very similar to a certified nurse midwife, but they're not nurses first. So they're just midwives. And then the certified nurse midwife, you're a nurse first, and then you go back to school to get a master's degree, and you're an advanced practice nurse. So that's the kind of key difference in those midwives.
So what are your thoughts in general about, not to be overly controversial, but what do you think about delivering babies at home?
Well, I think that it can be a great thing for women who are low risk. There are some people that you would not want to see deliver at home, such as people who've had surgeries on the uterus, whether that be a fibroid surgery or they've had a previous C-section. Their risk for complications is just higher. Also, if you have other comorbidities, or if you've had, like you've had blood pressures, or if you've had a history of preeclampsia, which is high blood pressures in pregnancy, gestational diabetes, there are things that could, potentially make your delivery more high risk. We may not want to have those patients deliver at their house, but there's a lot of women who are low risk who could deliver at home. And there are some studies that show that the low risk patient can have a successful, safe outcome at home, but it is definitely not for everybody.
As an obstetrician, when I was delivering babies, the idea of having a home birth was really very, very foreign to me, because I did all my deliveries in the hospital, right? And so we tried to make the whole environment in the hospital, even with our nurse midwives and the midwifery service, a home-like experience in the safety net of the hospital. And so that's what we wanted to do, because, even in a low risk situation, we've seen bad things happen very, very quickly. Things can really go awry pretty quickly, and so it makes me nervous. But there are certainly thousands of successful home births every year. So to those who are appropriate,
yeah, I think it'd be crazy not to be a little nervous. Even when I'm in the hospital, I get a little nervous. But have you ever seen a home birth? Ever?
I've never been present for a home birth, but I've seen some videos.
Okay. Yeah, you get to have a different point of view when you've seen some home births, and it kind of changes your perspective a little bit. I know I've been doing women's health and working labor and delivery for almost 12 years. And when you do kind of go and see those home births, you actually do get a little bit of more respect for it. You're like, wow, this is so different. We can do things a different way. But yes, it is nerve-wracking to not be.
So prior to becoming a nurse midwife, you were a labor and delivery nurse.
Yes.
Well, so you have experienced the full gamut. You've got here getting people pregnant all the way to having the babies, and so that is that's a wonderful thing. Let's see if we can jump over to some questions here. Angela asked if I am taking vitamin E for a transfer and also Lovenox. Can vitamin E function too much as a blood thinner? Well, the truth of the matter there is that you're on Lovenox, and Lovenox is a very potent blood thinner. So the extra, let's call it thinning of blood that you get with vitamin E probably doesn't contribute a whole lot to how thin your blood is or how your blood is prevented from clotting. So we know that there are five supplements that you should be on for embryo transfer. So let's review them. There's your prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. So vitamin E has a differing effect than just thinning the blood. It's improving blood flow that's going to the uterus, to the lining of the uterus, which is we know as the endometrium. But it also has an effect on sensitizing the endometrium for implantation. So you're really using those things for different purposes. Angela, yeah, I think that you're okay there. If you have a 5-centimeter fibroid outside of your uterus, or rather on the outside of your uterus, can you have a home birth? Well, it's a good question. So, you talk about fibroids. There are different types of fibroids. Good chance to review those. We've got fibroids that can be inside the uterine cavity, and those are called submucosal fibroids. And those are the things that in the fertility world we get worried about because they can impede the implantation of an embryo inside the uterus. There can be a fibroid or a ball of muscle that's in the wall of the uterus, and that we know of as an intramural fibroid. One that's more on the outside of the uterus is called a subserosal fibroid, or sometimes it actually sticks off the uterus like that and is what we call a pedunculated fibroid. So how would you counsel a patient who has, let's say, a subserosal fibroid that's maybe 5 centimeters?
I would look more of like, as far as home births go, if you've had surgery for a previous, it's definitely a no-go. And if it's just a smallish fibroid on the outside, I would probably want to know, like, do you have bleeding tendencies? Like, how are your periods? Things like that. I think I don't know, it would make me nervous to do a home birth with a fibroid, honestly, because they do bleed. And I have had patients who have fibroids that are subserosal or intramural that can cause additional bleeding during, delivery and afterwards. So I would probably say no, honestly.
So, it kind of depends on who your provider is. We don't want to give too much medical advice here, but in reality, a fibroid creates its own blood supply. And there's already so much blood supply that's going to the uterus at the, in pregnancy, and certainly at term pregnancy at the time of delivery. It would concern me as well about the possibility of having not an insignificant postpartum hemorrhage, which is where the blood comes out and it doesn't want to stop. So that's the kind of thing we'd be worried about there, Angela. Let's see, before we go over to my Instagram, we've got a question over here, looks like coming from YouTube, and I think that says Sean Lift, I believe. Is there a reason why a PGT tested euploid embryo keeps miscarrying, embryos keeps miscarrying around 8 weeks. Is it trial and error? I've had a laparoscopy, I've had Receptiva, Emma Alice, HSG, saline sono, and the works. So it sounds like you have run the gamut there, and you have one of the more frustrating things that we find in the fertility world, and that is a tested, biopsied normal embryo that still results in miscarriage. So first of all, our hearts go out to you for having to live through that. It's hard enough to go through the IVF process without having to, then face a miscarriage on top of it. That was the topic of my post, I think, yesterday on my Instagram. So I think, is there something else going on? Well, what we know is that a single euploid embryo should get you about a 65% probability of pregnancy. By the time you're on embryo number 2, it should get you about roughly an 83% probability of pregnancy. And by the time you're at embryo number 3, that's a 95% probability of pregnancy. Now, the thing is that PGT testing is not perfect. We are testing from the portion of the embryo that comes from the outside. So it's not actually taking a piece of the baby, it's taking a piece of the placenta. And you can have an abnormal baby part, but a normal placenta part. Conversely, you can also have an abnormal placenta with a normal baby. And so that's why we say, well, PGT is about the best we have, but it's really all we have, and it's not a perfect system. Now, if you've had multiple euploid tested normal embryos, which you're still miscarrying at 8 weeks, that suggests to me that there's something else that's going on with you. What could that something else be? What do you think about?
Immune issues like autoimmune.
So is there something in your body that's trying to prevent your pregnancy from sticking? And what is that? That's the immune system. So there are several things in the immune system I would probably want to take a look at. You are talking about what we know of as recurrent pregnancy loss. It is very similar to a situation we know of as recurrent implantation failure. And those two things can be very similar and often have some of the same origins as in something in the body that's trying to prevent that. So you say, is it trial and error? Well, the studies do show us that if you just keep putting in embryos, eventually one of them is probably going to stick. But that is a ridiculous statement to make when you're the one that has to go through all those embryo transfers, all the expense, all the emotional capital that you have to spend in order to, to get there. So I would say there's a pretty significant workup that we would want to do from the immune system standpoint there, Sean Lift. And certainly our thoughts go out with you there, because that is a tough one indeed. Let's see what else we have here. Sharmila asks, are DHA and fish oil both the same thing? So fish oil is generally known as omega-3 fatty acids, omega-3. And there are usually two types of omega-3 or two types of fish oil, DHA and EPA. So EPA and DHA. So yes, you are correct. DHA is one type of fish oil. What it is not is what's known as DHEA. DHEA is a separate hormone entirely. DHA, not the same thing as DHEA, but Sharmila, yep, you're absolutely right. And I think you must be about, are you close to 28 weeks now? I think, boy, that is just so exciting, because I remember the days, Sharmila. I remember trying to get there. There's Runner Girl Training. Hey, I hope you heard the answer before there. Megan Cade, hello to Earth Girl Peace. The Salustio clan says we have missed you and are excited to share that after 6 unsuccessful transfers, we are now 15 weeks pregnant with the little boy. Yay, that is fabulous. I am so happy to hear that. Boy, That is just great news. That is just absolutely awesome. Here's one from Rosa. My TSH was 3.14 after transfer. I took some levothyroxine for 2 months, and now my TSH is 0.1. I'm pregnant. Do I need to continue with levothyroxine now that my TSH is normal in pregnancy? So I would say in my opinion, the answer to that is no. It used to be that we would say we want your and there are still some practices that do this, so there's nothing wrong with it, that I want your TSH to be, and you may have heard me say this before, between a 0.5 and a 2.5. And if your TSH is above a 2.5, I'm going to give you levothyroxine because I want to bring it down. Now we know the data doesn't really support that it's really not necessary, that fertility rates don't so much change. But the thinking with that was that the fertility rates would improve by using that levothyroxine. Well, now, my friend, you're pregnant. So it doesn't so much have to do with keeping the pregnancy ongoing. And since 3.14 was a normal result, and TSH tends to go down in pregnancy anyway, I think you're probably okay to stop that levothyroxine, would be my guess. She says, thanks for being here. It's my pleasure, Rosa. Thank you very, very much. Is a prenatal with 800 micrograms of folic acid okay to take in pregnancy? And the answer there is yes. So
please do.
And please do. The minimum recommended daily amount of folic acid is
0.4 milligrams, unless you've had a history of some sort of issue, like if you've had anencephaly or spina bifida, then we would increase that. So
400 micrograms or 0.4 is the recommended dose. In most prenatal vitamins, there's going to be a minimum of 800. Some prenatal vitamins may even have 1200. So folic acid is very well known to decrease the risk for certain types of spinal birth defects. And so, yes, please stay on your folic acid there. Hey, Marianne, impeccable. I like it. Oh, Bobby Lieben is here. Dr. Lieben is one of the finest physiatrists in the southeastern United States. And if she's still on, then glad to have you here. Evans Beauty. This Bama Gal-Owl person is a very special person to me, and that would be my mother. So my dear mother and father are watching me from Mobile. Thank you very much for being here. Mwah! Nice to see you. And this is Jess from Dothan. Jazzy Poo is here. Hey, Nurtured Shanna, good to see you. Fij, Roxy Clay, we've got TBL Hockey. Hello, Zenaida in Miami. Thank you for being here. Oh, and she even said hi. Maria King. Midgie asks, how much of a risk to the integrity of the embryo does PGT testing perform? So, or does it pose? You know, you probably, we do some PGT. There are some practices that do a lot of PGT testing, but I'm sure your patients here, I will tell you, here in the Dothan office, it's a very boutique kind of practice. There's a lot of very, very personalized care because it's very small. And it serves this community in a very personalized way. And so a lot of folks will come and talk to you about things that they worry about, and PGT has got to be one of them.
Oh yeah, for sure.
How do you counsel people about the risk of PGT?
Well, first I tell people that we have a really high success rate with our PGTs. I know you mentioned 65%. We have about a 70% ongoing pregnancy rate with our genetically tested embryos here. And so I usually say, there is a risk anytime you put a needle into the embryo. There's always that risk of damaging it, but I feel like we would see lower success rates if the embryos were damaged to the point where we couldn't use them, you know. So I generally say it's pretty safe, pretty low risk.
Yeah, they've studied PGT pretty well, and you know, for a while there was some question, you know, does it does it cause this problem or that problem? And
I see what you're saying. Yeah, and we have good studies. We actually are a member of SART, that's Society for Assisted Reproductive Technology, and we give all of our information to them on every embryo that is made. You know, what happened to it, where did it go, did it have a pregnancy, was mom okay, was baby okay? And that's not just us, that's all of the SART, IVF clinics in at least the United States. I don't know how much further out, but they give us these statistics, and we know that doing PGT does not increase the risk of autism or congenital anomalies or intellectual disabilities or anything like that. It doesn't decrease the risk either, but we don't see an increase in risk. So I always tell people, it's still your genetics, but
I agree. And so I would say, really, it's a pretty safe thing to do. And you think to yourself, well, gosh, I don't want anyone, potentially hurting my baby. And I completely understand.
Yeah.
And my baby is so small at that point, it's just, a bunch of cells. So to take 5 or 6 cells off of there is, maybe that has some significance. But the truth is, it is a very safe thing to do. And then, after that, you're talking about freezing and thawing an embryo. The success rates with freezing and thawing embryos are really, in our lab, it's above 98%. In most places, I think you would quote it's above 93%. But I'm told that even if it's 93, you'd say it should be higher than that, and it probably is. So we've come so far in learning how to freeze and thaw embryos that I would consider it to be a very safe thing. Happy to see Shanna here. Our transfer is on Friday, and a week later I'll be driving about 9 hours to visit family. I'm worried about circulation on a long drive. I'll stop regularly, but would you recommend compression socks too? Well, the first question is, are you traveling to see in-laws? Because if they're in-laws, then I am very worried about you as well. If, however, it's your own family, well, then maybe that's okay. How would you counsel Shanna about that?
I think it's great that you're going to take frequent breaks. With the extra estrogen in your body, you are a little bit more prone to a blood clot. If you want to wear compression socks, you can. I don't think it's absolutely necessary. If you have them, throw them on, but I wouldn't go spend money on that for a 9-hour drive where you're going to be up and walking every hour or so.
Right, because the truth of the matter there is that, so the data on compression socks, or what we'll call TED hose, they really don't do such a great job at preventing blood clots. And think of it this way. How many hours, Shanna, do you sleep a night? You sleep 8 hours, 9 hours, maybe you get lucky and you get 10 hours of sleep. Well, you're pretty much not moving around under that circumstance either. And so the odds of you getting a blood clot every night when you go to bed, fortunately, are pretty low. You are going to be getting up to fill your tank with gas and walk around and get something to drink and go to the bathroom probably every few hours. So in general, I would say I think you're probably pretty safe in doing that. Now, if you told me, hey, I'm having my transfer and then 4 weeks later, I'm taking a plane flight to Australia and New Zealand, I'd say, wow, that's a long flight. It's like 22 hours or something, depending on where you're going. That kind of thing might worry me a little bit more. You want to make sure that you're moving around, and prolonged plane flights are probably a little bit more challenging to us because of the dry environment in the aircraft than it would be driving in a car. So I think you're probably pretty good shape there. Hey to Kim Trees, who is our office manager at New Life Fertility in Pensacola. Angela asked, I have an autoimmune disease, but not sure which one. Would Plaquenil work better than tacrolimus? So tacrolimus in particular is a medication that has been shown to decrease the risk for recurrent, or rather, it's been shown to decrease implantation failure in those with a history of recurrent implantation failure. So it's a very strongly evidence-based drug. Plaquenil can treat certain types of immune conditions, but specifically, there is and if that immune condition that that you have is one of them, and that's things along the form of lupus and rheumatoid arthritis, then maybe so. But particularly if it is to prevent implantation failure, tacrolimus is really the better drug. Now, you can't take tacrolimus. You can't take tacrolimus with Prograf. Prograf and tacrolimus are contraindicated together. So what some people do who have to be on the did I say Prograf?
Mhm.
I meant Plaquenil. Plaquenil and Prograf are the two drugs, or Plaquenil and tacrolimus. I think I got confused there. You can't take those together because they can have a cardiac effect. So for the people who need to be on Plaquenil, you would take the Plaquenil, and then at some point you would stop and switch over to the Prograf,
Yeah.
the tacrolimus.
I would just add, I've had a few patients who specifically need the Plaquenil, and a lot of people want to come off of it. And I typically say we would want to stay on it, specifically with people who have like rheumatoid arthritis, positive SSA and SSB antibodies. It can help prevent heart blocks in babies. So I have had patients in the past where even though it's not a category A or B medication, we still, there's still benefits to those.
100%. Let's see here. What else we got going on? Our friend Devo joined us. Is having a subchorionic hematoma an issue for having a home birth? Well, how do you say? What do you
I
say
don't think
to that?
so.
No, because
No.
that subchorionic hematoma will be gone.
It's going to self-resolve within
by the
usually
time
by
you
the
deliver.
usually by the second trimester. It's gone without any interventions. So
A subchorionic hematoma is a collection of blood that exists underneath the placenta, and that is typically a first trimester finding, sometimes an early second trimester finding. But by the time you reach time for delivery, that'll be long gone, my friend. So that's a good one. Hey to Monkey Mo, yours truly, Alina. Hi, Rosa. Hello, my friend Angelina Foxy, who is one of the most fabulous cardiac nurse practitioners I have ever met. Live like Coco to Dr. Fink, and friend. You are the Fink, you are the friend. I am Fink, you are friends, and she is a friend as well. Signal not good from the UK, so maybe have to catch up later. Oh, I'm sorry to hear that you can't hear us in the UK tonight, but thanks for being here. It is a nurse practitioner special tonight. Alexis Lorente is a superb nurse practitioner in Miami, Florida, and the person who you want to go to for women's health in that region for sure. Ashley says, thoughts on a loss at 8 weeks for someone who tested positive for a variant on the F5 gene, the factor 5. F5. Do you mean like I wasn't on any anticoagulant other than aspirin? So I think maybe you're talking about something that's known as factor 5 Leiden, I believe is what you're saying. And I'm going to guess that's what you mean. So factor 5 Leiden is one of the factors in the blood that correlates to the body's desire to make little blood clots. And these little blood clots, sometimes bigger blood clots, but when these blood clots are little and they affect the placenta and the blood flow to the uterus, they can cause the pregnancy to end. So what's been your experience with folks who have, those are called thrombophilias. Factor 5 Leiden is one. There's another that's called lupus anticoagulant, and these folks, are often diagnosed with a history of recurrent pregnancy loss. But once we put you on anticoagulants, you can have a pretty normal pregnancy, and I'm sure that you've seen some of those folks coming in
absolutely
to have nice normal babies,
yeah.
right?
And it's super easy. Lovenox is typically what we would use. It's injection in the belly daily, and it works really well for most people. And if you get pregnant again, I would highly recommend that you talk to your doctor about starting that.
So, Ashley, my guess is that maybe you had some pregnancy losses, and that's what caused them to test it. Now, there's a different story when someone says, "Hey, I want to have all these blood tests done." And so then your doctor agrees to it for some reason and draws a bunch of blood tests, and you come back positive for factor 5 Leiden, but you've never had a pregnancy loss, you've never had a blood clot, you've never had anyone in the family with a history of those things. In that scenario, it gets a little more complicated, a little more confusing as to how we should treat it, because you don't technically have the syndrome there.
Right.
But with things like that, we get concerned about being on hormones. So things like birth control later on, we would worry about, and things like pregnancy. So the anticoagulant, as Jess said, is actually pretty straightforward and pretty easy to use. Speaking of injections, Jess does a lot of our medication teaching for our patients who are undergoing IVF. What do you think is the most, in your experience, and in fact, maybe if you've been through it as well, what do you think is the most difficult medication to use from the injection standpoint?
Progesterone oil, in my opinion. And I have gone through two. I've never done IVF, but after having my 3 kids, I was a surrogate twice. And so I've done the frozen embryo transfer cycles, but never the retrievals. I have heard some of them burn, but the needles are very little, tiny, 30 gauge, short. But the progesterone oil is a little different. I've done a little, doing them myself. The largest needle, or I guess smallest gauge needle you could use successfully is a 22 gauge. And it's still kind of hard to push, and it leaves lumps. And where you're giving it is much more difficult. Some people need a friend or, someone else to give that shot. Whereas when you're doing the sub-Q, it's super easy. You can see it, you can do it. It's super quick. So I would say progesterone and oil.
So a sub-Q injection is just going into, you just pinch an inch and inject right in. And those are super tiny needles, right?
Very tiny.
Yeah, progesterone and oil, or what we call PIO, is a real challenge because it's a big needle and it's going in your butt, and you can't really see it very well. And it's a thick liquid, and you got to use a big needle. The way she talks about the gauge of the needle, the lower the number means the thicker the needle. And so if you're talking about something like an 18 gauge needle, that's a big needle. Yeah. A big bore needle that has to go into you. And so doing those PIO shots is never easy. And so, yeah, sometimes it is helpful to have a friend who will give you the shot. I've known people who will go to the fire station to get that shot. One of the things that we do a little differently here at New Life Fertility for our medicated cycles for embryo transfers is that we will use the progesterone and oil every 3 days as opposed to daily. And our pregnancy rates are great. So that may be something to think about if you're going through an FET, to discuss whether using the PIO less frequently is going to be an option for you. Now, what I'll tell you is that depending on the practice you're in, they may not have the experience with that. They may not have the throughput to be able to offer you those kinds of individualized options, but we do it every day here. Or we do it every 3 days, I guess I should say. You still use a vaginal suppository, yes. So you get some local effect from the progesterone, but you don't have to do the shot. Now, if the shot is something that is just not in your cards, and there are some people who say, I just can't do that. And that's okay, because in a natural cycle or a modified natural cycle, your body makes its own progesterone, so you don't have to use the injection. And I think that's another very good reason to consider doing a natural type cycle or a modified natural instead of a medicated cycle. The advantage of the medicated cycle is that we can control every variable. We can control everything so that there is never a question, there is never a doubt about how much hormone your body is getting and on when things are going to happen, because we are making sure your body's doing it the way we want for it to. And so, you need a little more flexibility with a modified natural type transfer. Now, Jess, you were a gestational carrier.
Yes.
That is fantastic. What a beautiful, wonderful gift to give to someone. What must that, I've always wondered, what must that be like to be able to carry a baby for someone who can't?
Very cool. Very cool. I never thought it never crossed my mind to do that until I started working in a high risk antepartum unit, actually, in Nashville. And a lot of the patients there had done IVF, and I really didn't know much about it. And I just was, I don't know, I guess I felt led to do it. So I went through an agency, and they said, you're a good candidate, which was perfect. It was very straightforward. You actually take some questionnaires. They match you with somebody when you're using an agency who has similar views and ideas and things like that. And they did a great job. I absolutely adored, we call them intended parents, both times. And we had a great relationship. They still send me pictures.
Oh gosh.
I follow them. Wonderful. Yes. The first surrogate baby, belly buddy, as I say.
Belly buddy. Like that.
She's about to be 5 in July. And the second one just turned 3. So I got a little picture of him. So that was really cool. And then that kind of led me to doing fertility, actually. About 5-6 years ago, I was like, this is super cool. I love this. I didn't, growing up, even know that fertility was a thing because it's so hush hush, and people, I think
don't talk about it.
Yeah, they don't talk about it, but 1 in 6 couples experience it more than people think. And so that's kind of what led me into being in fertility.
Well, you are from heaven, because I just can't even, it's so overwhelming to think about, how much we love our children, even our unborn children, before we get to know them, and being able to watch them grow, and to be able to give someone that gift who wouldn't otherwise be able to do it is just really heartwarming. But I have to ask, what's it like then to look at the baby and then give the baby to someone else?
For me, it wasn't hard. And it wasn't my egg, it was theirs completely. And in my mind, it was not my baby. And I mean, obviously they did everything, ate healthy. And we were talking about epigenetics earlier. I even was trying to be happy all the time. I'm like, I want this baby to not have any problems. Like, I really and genuinely cared for the babies. But at the end of the day, I'm like, I have to buy a car seat. When I had my 3rd kid, I was like, I gotta get a minivan, all the things you think about when you're adding someone to your family. I didn't have any of that stress, any of that worry. And it was funny because when the first baby was born, I saw the baby come out, and I was unmedicated. So I was like, oh my gosh, so great, baby's out. But I saw her foot, and it was so big, and she had a little bit of red hair, and I was like, that's definitely not my baby. So, the thought kind of, take a little peek. Okay, doesn't look like me. We're good.
Okay.
It was great. And my second one, the intended mother was holding my foot, and I looked over at her, and she just was crying. And I was like, that moment made it so worth it. I was like, she's going to be such a great mom. So
that is just fantastic, Jess. If I didn't have reason to respect you before, I certainly do now. That, God bless you for that. Let's see here. Hi from San Diego to Mohai Amal. Let's see who says, I am old young. I have 3 frozen 3-day embryos. Do you recommend transferring 2 for a better chance? Also, should I do more rounds of IVF to bank more embryos? Oh, I see. There you are. You're 48 years young. Okay. Well, so the answer to your question is that if I were taking care of you and we had your day 3 embryos, I would say, yes, we can put in more than 1 embryo at a time, because the odds of any one of those embryos sticking at 48 is fairly low. So the more embryos we have, the greater the odds that you will end up with a pregnancy. Should you do more IVF before you do a transfer? Well, certainly you want to maximize the number of embryos you have. However, making embryos is difficult at 48. So I would want you to kind of be aware of what you have to spend to go through with that, both financially and emotionally, with the understanding that it's definitely an uphill climb at that point. But so glad you are with us from San Diego tonight. By the way, it is a quarter till the top of the hour. We'll be here for about another 15 minutes. I'm Dr. Randy Fink from New Life Fertility, and this is Fertility with Fink. And my friend Jess here, Jess Williams, nurse practitioner at New Life Fertility in Dothan, Alabama. Steph asked, do you recommend the GLP-1 medications? And my answer to that is almost unequivocally yes, but yes with a but, because you can't be on those medications when you're trying to get pregnant. The recommendation is that you have stopped the medications 2 months before achieving pregnancy. Now, why is that? Is there something inherently dangerous about those medications? And I would say the answer to that is no, probably not. They just weren't studied, and so they weren't approved by the FDA for pregnancy. So eventually, I do think that that will probably change. I think at some point there will be enough data in the registry that they can say that it's okay with pregnancy. But for now, the party line is you stop your GLP-1 medication beforehand, 2 months. What do we know about GLP-1s and what they do to people's bodies? They do good things. Would you agree?
I agree.
Not only does it help you lose weight, but they also improve things like insulin resistance and various issues in the metabolism and lower your inflammatory markers. So I feel pretty strongly that the GLP-1 meds are a pretty good thing that has happened to us. Now, you may know that your insurance company doesn't want you to be on a GLP-1 because they're expensive. And so they will make you jump through every hoop you can imagine. And except for a pretty narrowly defined group of people, they will deny you coverage of the medication. So you can get compounded versions, which I think are okay. People talk about, oh, you shouldn't use compounded medications. I think, that's a whole other conversation, but I really do believe that a lot of that comes from the pharmaceutical industry who is trying to, retain their profits on the medications. So I do think the compounded GLP-1s are okay and are really affordable for almost everyone. So yeah, I think that's a good thing. Let's see, are there lifting restrictions after a frozen embryo transfer? Well, how would you counsel somebody?
I usually just tell people if you've done it regularly, you can kind of keep doing it. I wouldn't start anything new. I mean, I wouldn't start yoga if you've never done yoga. I wouldn't do CrossFit if you've never done CrossFit. But, and especially right after the transfer, maybe 24, 48 hours, kind of just make sure there's no increased abdominal pressure. But once it was implanted, I think it's fine if you lift weights to lift weights. But what do you think?
Yeah, I agree. It's not the right time to start a program. So I always tell people at the time of embryo transfer, I don't want you going bungee jumping. I don't want you going skydiving, alligator wrestling, extreme snowboarding, that kind of thing. But pretty much if your routine involved weightlifting before, then I think it's okay. I'd give it, usually like 48 hours. So if you want to be safe, give it a week, or if you'd really like, wait to get your positive pregnancy test, and then
Nothing wrong with that.
then everything is good, after that. Hi to all the folks who have joined us there. Let's see. We got to that one. Let's see, I wanted to talk a little bit more about things like donor egg, because we talked about you as a gestational carrier. And, there are some folks who have to who go through the process and have to end up using genetic material that comes from a donor. No one goes into the fertility treatments hoping to use a donor's embryos. Everyone would like to be able to use their own. Well, you are very unique there because you used someone's genetic material to carry in your body. So maybe you have a different perspective on how you counsel folks who are using a donor egg.
Using a donor egg? Well, it's kind of, most of the time it is a difficult conversation because like you said, they come in, everyone is kind of like, they want to use their own eggs. And when you get that diagnosis, a lot of times after you get the diagnosis that you may not be able to use your own eggs, I usually do a follow-up phone call because they're not going to hear anything I'm saying that day, but it can be a wonderful thing. Some people will use donor eggs. Some will use donor embryos, which I know you haven't touched on a whole lot. But it can, you know, a donor embryo can be a good halfway mark between IVF and a traditional adoption. You know, you get to carry the baby. It is your baby. You grow it in your body. You get to breastfeed. You get to bond. And everyone's a little different, but I think it can be a good thing, and it can achieve what you want, which is a family, and that's going to be your baby.
And that is the most important point, that it is getting you to achieving what you're after, which is your family. So we talked a little bit there about, so we talked about being a gestational carrier. Do you draw a distinction between the term surrogate and gestational carrier?
No, what do you mean?
Well, so in many times people, so, you know, the kind of term that we typically use now is a gestational carrier is someone who will take an embryo that was made elsewhere and carry that pregnancy, as opposed to a surrogate is often someone who will use their eggs with a partner sperm and then carry that to pregnancy.
Okay, so maybe I'm thinking of traditional versus gestational, but so if you're talking specifically about using donor eggs to have your own baby, I wouldn't even I don't even say you're a surrogate. I mean, that's
in that scenario, that's 100% your baby. So then we've got the possibility of a donor egg, the possibility of a donor sperm, and you also talked about donor embryos. So what is a donor embryo? That's
when you have you can either have somebody who has gone through IVF and their family is completed and they did not want to continue to store those. They don't want to destroy them. They don't want to give them to science. So they would, take them to an agency that where someone else can go in and adopt those embryos, and then they can, have a baby. The other way is some places take donor eggs, donor sperm, and they make embryos. But essentially, it's the same thing. It's just eggs and sperm together making an embryo, and it's not you or your husband's. It's not your eggs, not your husband's sperm, and so that's donor embryo.
There are a number of, as I'm aware of them, Facebook groups for folks who are seeking donor embryos. And I have a friend who is going through that process now. She's got embryos up in the Mid-Atlantic region, and they're being transferred to us. And that was exactly the scenario, that the couple that made those embryos had their kids and have some remaining embryos. And rather than destroying the embryos or just keeping them frozen forever, they have donated them to another couple who was not able to have a baby of their own. So that's what I think of with the donor embryo. Again, a beautiful gift to be able to give to someone else. And there are a number of social media outlets, oftentimes faith-based, that where families can get together and learn about the possibility of embryo donation. Harrison says, my AMH lowered in the last 2 years from 2.65 to 0.4. Last IVF gave me one good embryo, but ended up in a miscarriage. Now I am in another second cycle. So the AMH is what I consider a qualitative measurement of what we know of as ovarian reserve. We said before that ovarian reserve means, well, you're born with all the eggs that you'll ever have. And those eggs are hanging out in your ovaries and waiting to do something. Over time, we tend to lose those eggs. Some of them we lose to ovulation. Some of them we lose to just aging. They start to diminish.
Genetics.
So what causes, and if you look at a graph, we'll see that graph does go down over time. Now, that kind of number there, going from 2.65 to 0.4 in 2 years, suggests to me that something happened there. What happened? Well, I'm not sure that we'll ever really know, but that's somewhat of a precipitous drop. Now, the number itself is not a perfect system, so it may be that you check that number again and find that it's actually higher than it was. It may be that the first one that you had at a 2.65 may not have been realistic. But some of the things that are most associated with rapidly diminishing ovarian reserve are things like ovarian surgery. If you had to have a cyst removed from the ovary, for instance, that can do it. Endometriosis can do it. Smoking can definitely do it. Yep. And exposure to toxins and chemicals. And that's actually a very important one there, tobacco smoke. And even vaping is associated with a rapid decline in the AMH. But the AMH number does not say that you can't have a baby. Nor does it say anything about when you're going to go through menopause, if you're near to menopause, or what else is happening in your body. Really, all it suggests is how your body is going to respond to those IVF medications. So sad to hear, certainly hear that there was a miscarriage there, but you're on day 6 of a second cycle. And your estrogen level is 96. Well, so the first thing I would wonder there, Hira, is if you were on letrozole as part of the stimulation for your cycle, because if that was the case, then that will artificially lower your estradiol level, in which case the estrogen level really becomes not so meaningful in terms of what it means for you there. A special hello here to, and Amira says, mine probably due to endometriosis. I thought I just saw Caitlin. I sure did. Hello, Caitlin. It's nice to see you here today. Earth Girl Peace says, Jess, can IVF patients have a midwife, or do we need maternal fetal medicine?
Well, I don't think that IVF inherently makes you high risk. That is a question that's going to vary between kind of where you're at culturally, I think too. Some places will send you to maternal fetal medicine if you've had IVF no matter what. And we actually do that in Tallahassee. And some places couldn't care less. There are certain things that IVF can put you at risk for, such as preeclampsia. But I don't think that you couldn't start off with a midwife if you are otherwise low risk.
And I would agree with that. So when I practiced OB, just because you had IVF does not mean that you can't be a low risk pregnancy. I did get this question every Friday we do Ask the Doc on my Instagram, and that's Randy Fink MD. And that was one of the questions that I wasn't able to get to. Why do some practices make all IVF patients high risk? And I think the answer to that is probably because, well, it may be doctors' preference that, gosh, you had to go through so much to get yourself pregnant. We want to make sure that we are following you with, everything that we know how and every specialist we have so that you have a safe and healthy baby. Mm-hmm. But even a general obstetrician is very, very highly trained to recognize when there's a problem. Yes. Same thing with a midwife. Everyone knows their limits. And if there's an issue, then you move on to get the next level of help. Yeah. So in my opinion, I think it's—
And actually you can be cleared from maternal fetal medicine. And a lot of our patients are cleared. They see them once, maybe twice. They're like, you're good. And they don't have to see them the whole pregnancy. So it's never going to hurt to have extra eyes.
And sometimes what will happen there as far as MFM or maternal fetal medicine or high risk OB goes is that they'll have you in, they'll do your ultrasounds there maybe. that they'll do some of that monitoring for you, but your care is, really taking place in your OB practice. And I think that's a very good way to collaborate with a specialist, and then you don't have to really worry so much. Hey, folks, it's really top of the hour here. We've had a great time with Jess Williams, our nurse practitioner and nurse midwife here. I'm so happy to have you,
Yeah,
Jess.
it's fun.
If you're ever in Dothan, Alabama, you know the place to go if you have fertility concerns, and that's with us at New Life Fertility. I want you to remember, what I always say, and that's that this fertility business is not the book of your life. It is only a chapter. And what are we here to do? We are here to rewrite it together. One foot in front of the others, my friends, every day forward with love, with kindness to your fellow man, and with the knowledge that tomorrow is a new day full of all new adventures. So until next week, I'm Dr. Randy Fink. This is Fertility with Fink, and this is Jess Williams. Thanks so much for being here, and good night.